Hi, good afternoon from the annual meeting in San Diego. We're pleased to have Dr. Paul Singh. Paul, thanks a lot for being with us today. We always love having you on the program.
Thanks for having me. Appreciate it.
Paul, one of the really interesting topics that you're speaking on at this conference is about the iStent inject and how much intraocular pressure lowering we may see with MIGS devices such as the iStent in comparison with cataract surgery alone. What have some of your findings been?
Sure. We looked at the phase 3 pivotal trial data, and we did a post-hoc analysis. I think the question comes in is, how much is phaco really doing, right? Phaco does do a lot of work, but also how much is that doing versus the iStent inject? And so we segregated the groups into baseline unmedicated IOP. So we had unmedicated IOP baseline of 25 or less, 25 to 30, and a group of 30 or greater. So if they came in unmedicated with those three groups, we looked at those separations. Yeah. In those three groups, phaco itself had a max effect. So whether you had low IOP or high IOP, it was 5.5 to 5.8. But in the iStent with phaco group, you saw that as you increased unmedicated baseline IOP, you saw an increase in the actual magnitude of reduction using the iStent. So what it showed us was that, yes, phaco does do something, but there's a max effect that phaco has versus the outflow facility is increased with the iStent because as you increase unmedicated IOP, you get a further reduction with the iStent.
So it seems like, Paul, what you're saying is that the higher the IOP to start with, the more benefit you may get from the iStent in combined with phaco as compared to just phaco by itself.
Absolutely, and that's why a lot of times you have a patient coming in, pressure's 23 or 24, unmedicated, right? They're glaucoma or ocular hypertensive. You do an iStent, you're like, well, was there a significant difference between phaco or not? We don't know, because at that lower IOP, phaco is doing something, and there's not a big separation. But as you get to pressures of 28, 29, 30, you see much more reduction, and we're not always washing people out in the office. They're on medication. So this finally gave us an answer that yes, phaco does do something, but there's still the iStent giving us better outflow facility versus phaco alone.
True. So it seems like for patients that have very high intraocular pressures that are presenting for cataract surgery plus MIGS, that the MIGS procedure makes a lot of sense. With patients' pressures of 30 or higher, you're really getting a lot of bang for your buck. But I think we need to be careful in not assuming the opposite. I think we need to be careful in thinking about perhaps normotensive glaucoma patients whose pressures may be in the teens. I guess we need to be careful in not saying, well, MIGS should not be offered in these patients because we need a higher IOP to have it be effective. Does that sound about right?
Absolutely.
Yeah.
Look, understanding the fact that not only are we reducing pressure, and there was a 1.6 millimeter additional reduction in pressure, compared to phaco alone, but as you get to lower IOPs, what iStent can do and these MIGS devices do is they stabilize the pressure. Also realizing that fluctuating IOP can be a risk factor in certain patients, and compliance sucks. We all know that, right? So if patients are not compliant, we also see peaks and troughs of medications. So if we can stabilize that IOP over time, even if it's only 1 or 2 millimeters of mercury additional reduction, that's still a benefit for those patients. So absolutely, it's not just for the high IOP patients.
Paul, this is some really great advice. I want to ask you in closing, what kind of resources can you suggest for anterior segment surgeons who may not be so familiar with the MIGS technology and the process of implantation? Where should surgeons start in learning about this so that they can offer it to their patients?
Well, I think a lot of the companies are more than willing to help out. They'll come, Glaukos, for instance, has a great training program, and other companies have great training programs, and you reach out to them, and they will come and show you how to do gonioscopy, how to implant, to do a dry lab in your office, and do a wet lab as well. So the companies are really engaging with the providers as well. I think they want to show and educate. Also, I think online, iTube and YouTube and all these different websites, I think we see a significant number of videos now showing instructions on how to get involved, and then peer-to-peer. Reaching out to fellow providers and surgeons, I think, can really help a great deal.
Well, Paul, this is a fantastic study. I'm so glad you're able to share your data with us. It's always wonderful to have you here and to learn from your expertise. Thanks so much for being here today.
Thank you so much. Appreciate it.
And thank you, of course, to our live audience for your support as well.